I'm Dr. Charles from PHI Preventive Health Institute, where we discuss real clinical cases with real daily implications. Today, we are talking from a pharmacy perspective about medicines used in children for sinus and stomach-related symptoms, and why how these medicines are supplied, taken, and continued determines whether a child fully recovers or keeps cycling through illness. There is a pattern that is very familiar in real practice. A child develops symptoms: runny nose, nasal blockage, facial discomfort, sometimes fever, or a different presentation, recurrent abdominal pain, poor appetite, discomfort after meals. Care is sought. Medicines are prescribed or dispensed. Treatment begins, and then the system responds. Symptoms improve. The child feels better. Appetite returns. Activity improves. And at that point, the pattern shifts. Doses are missed. Instructions are not followed exactly. Medicines are stopped early. Or the same medicines are reused later without reassessment, because improvement is mistaken for completion. But that is where the real risk begins, because in pharmacology, improvement is not the endpoint. Sustained therapeutic exposure is. Now step into the system. Medicines work in a controlled rhythm inside the body. Correct dosing leads to stable drug levels, then symptom resolution, and finally full recovery. Interrupted dosing leads to fluctuating drug levels, a partial response, and then relapse. So when medicines are used inconsistently, the system becomes unstable. Now consider antibiotics used for sinus infections. For example, cefuroxime. Antibiotics depend on time and dose consistency. When doses are missed or the course is stopped early, drug levels fall below the effective range. Bacteria are exposed but not fully eradicated. Surviving organisms persist in the system, and the pattern develops. Interrupted antibiotic use leads to incomplete clearance, persistent infection, and recurrence or resistance. This is not theoretical. It is a common dispensing and adherence issue seen in real practice. Side effects like mild diarrhea or nausea may occur, but stopping treatment early introduces a far greater long-term risk. Now consider antihistamines, for example, cetirizine. These medicines control allergic symptoms. They provide symptom relief, but they do not treat infection. When used repeatedly without reassessment, symptoms may appear controlled, but the underlying trigger may remain unaddressed. And in some children, drowsiness or behavioral changes may appear. Reliance on symptom control replaces proper diagnosis. Now consider acid-reducing medicines, PPIs, used for suspected acid-related symptoms, abdominal discomfort, reflux, or feeding intolerance. But when used without clear indication or for prolonged periods, normal digestive balance may be altered. Underlying causes may be missed. Now step back and look at the full dispensing system. Correct prescription, dispensing, and dosing instructions, complete course adherence, appropriate duration, all are connected. Remove one step and the system becomes unstable. So the key message is simple. Medicines do not fail randomly. They fail when the system of use is not followed correctly. Final point. Improvement is not the endpoint in children's treatment. Complete and verified recovery is, and that only happens when medications are taken exactly as dispensed, completed fully, and reviewed before being repeated. If symptoms keep returning, or if medicines are being reused without review, do not continue the cycle independently. Seek review. In children, medication used today determines not only recovery, but future treatment response. Contact your provider for evaluation.